Well, hello friends. Uh, Thank you for joining, and we have created a new GPT. I hope you can see it on the screen. So, MedRCA GPT on root cause analysis. So, first let us try to know what is root cause analysis. Is there anyone from community medicine here? You can raise your hands. Okay, just I have allowed you to unmute. So we all have some kind of problem, some kind of error, something happening in our ecosystem, whether in the hospital or in the lab or in the classroom. And there is a root cause analysis is basically a critical tool by which we find out why this problem is occurring. Instead of fixing the blame that so and so did wrong, or raising our voice or something like something, which doesn't solve anything. We try to go into the underlying causes of the medical error. Why is the students are failing in this exam or etc. etc. So this helps the organizations to create to sort safer environments, and this is applicable not just in medical sciences, it is a tool in all the industries. So in this we identify the factors behind the medical errors and the adverse effects, and this focuses on the how and why of the medical errors, and thus we work on solving them. Those who are involved with National Accreditation Board for Hospitals, they must be quite understanding it, and those who with the NAC inspections also, this is an important tool. So there are four approaches. One is the systems approach, and in this we identify the errors, the direct errors, and some kind of a latent error, the system error, and find out if this system error results in multiple failures rather than individual mistakes. Second is the multidisciplinary investigation. This involves a lot of data, asking a lot of people, staff interviews, reconstructing the event, and ultimately finding out why the error occurred. Or there are 5 whys of questioning. And in this, we continuously ask, why did this occur? 5 possibilities. Then another deeper why. Why? We go on asking deeper and deeper why. And then we address why this is occurring. And then there are preventive interventions, and then with this we develop some solutions and prevent the errors in future and focus on sustainable changes. We will discuss all them live when we go to the RCA. And common root causes could be one nurse not giving proper handover to the next shift, or unclear documentation, a wrong SOP, or hierarchical barriers to speaking up. Human factors, the fatigue, burnout, cognitive overload, frequent workflow interruptions, organizational issues like inadequate staffing levels, outdated or unclear policies, poor leadership, or environmental factors, for example, equipment failures, poorly designed workplaces, patient-specific vulnerabilities. These are common causes, or it could be just anything. Anything which we want it should happen this way, and because it did not happen this way, then it is a error. And we try to find out why that occurred. And there are multidisciplinary teams involving from top to bottom in finding out the root cause analysis, which may include nurses, clinicians, support staff, ward boys, seeing top leadership to see all the perspective in an event. And also this makes a good culture, and it creates frontline insights amongst all the people in an organization. And there is management support. Leaders ensure to provide enough resources, training, accountability for implemented the recommended changes. I'm just taking an outline because we will go to the practical. So for this, there are certain tools, fishbone diagrams, they are visual tools which involve the major groups, processes, people, equipment, environment, etc. Or failure mode and effect analysis, which is proactive assessment tool, which identifies potential failure points before they actually cause harm. And the actionable hierarchy tool, in which the framework for prioritizing the common corrective actions based on effectiveness from stronger to weaker interventions. We are working on the health system, and from bottom to top, root cause analysis is useful. And with the broken healthcare system in our country from top to bottom, this is an important requirement. And I'm just taking generic right now. The implementation gaps are that many organizations, they fail to consistently follow root cause analysis recommendations, they're limiting their impact. There could be resource constraints. There is a blame culture in the institution that, okay, so and so, one person blames the other, he blames somebody else, and nobody works on the system, which is causing the lot of heartburn, but still efficiency does not come. And the fear of regulatory penalties, they further impede the honest analysis. And quite often there is limited evidence also that, okay, this is causing this problem. And generating that evidence is again an important uh, task, and though it is a difficulty in measuring. So, root cause analysis all over the world, not only in medical sciences, everywhere it is useful tool for finding out the problems and their solutions. And there is one event like there is a blood transfusion reaction in the after giving a blood, or there is a drug reaction, or the mortality rate has increased, or there is a class of students in which a test is given and the large number of students have failed, or it could be the attendance is too low, or certain competencies they are majority of the students are poor in that competency. So the process is, first there is an event, and then we subject it to an RCA process, and there are multidisciplinary teams. They assemble within 24 hours and investigate why this happened, and we just investigate this. Then the intervention, what are the possible implementations? The interventions are implemented, and then there are results. And to see whether by those implementations are we able to do it. So, key takeaways: RCA is a systems approach, and the focus on identifying and addressing systemic vulnerabilities rather than creating an individual blame. And most errors result from multiple system failures. And in the end, dealing with these root cause analysis, it requires thorough training, leadership commitment, and adequate resources and consistent follow-up to achieve it. The culture of the institution also matters. That encourages error reporting and values learning from mistakes. And of course, system integration is the key. With this, now we will be going to doing it practically on the actual, because I like only practical work. So, meanwhile, would anybody like to say something or ask something at this stage? You can unmute. How many of you knew about root cause analysis before?
मेरे लिए फर्स्ट टाइम है सर, पहली बार ही सुन रहा हूँ. गुड इवनिंग.
Okay. I mean, root cause analysis is a very common tool of those who work in community medicine or
Okay.
hospital administration.
Okay. Okay.
So, I mean, it is their quality control tool, and Dr. Rekha is saying IRCA and Kappa, RCA and Kappa. What is Kappa, ma'am?
Corrective and preventive action.
Yes, something like that, yes. So just first you analyze what is the problem, and then you go into the corrective action. So Dr. Ganti Mathi is saying, how can this be applied to academics? We will just show you. So I have some possible examples ready, and I mean, basically, in academics, supposing you give the students a particular test, say it could be a OSCE exam, it could be just any MCQ exam, it could be going to the skills lab, it could be anything. And after going there, the students perform very badly in that particular exam. I mean, that intervention has not resulted in anything. So it is a failure. So you just go to apply RCA, and whatever the recommendations are, that this is what we wanted to achieve, this is what we did. And I mean, it's not that we are doing any doing things for the sake of doing things. We want a particular result that the students should improve as a result of this particular intervention. And this is this requires certain effort, but once you know the causes, then it is you apply them and you reassess after some time that whether after a new intervention, whether you can apply it or not. Okay, and now we go to, okay. So this is a MedRCA GPT. The link for this we have already given in your WhatsApp group and also in the MEUINDIA Google group also. So there are two things in this. You have to give the GPT certain two things. What is the problem you want to solve, and describe the problem in detail and give some extra detail if you want a more specific answer. So we have some possibilities. So paste. So there is a medication error in the intensive care unit. Analyze how a wrong dose of insulin was administered and prevent its recurrence. So this is the problem. We have taken insulin as an example. It could be any drug. So let's see what it does. It is thinking. This can be applied to anything. Yes. So root cause analysis of medication error in ICU involving wrong insulin administration. So it has given us the event title, wrong dose of insulin, date of analysis. It has given some, we can provide this, change these names. These are dummy names. And the patient in the ICU received incorrect dose of insulin resulting in hypoglycemia The error was discovered using routine glucose monitoring for 45 minutes post administration. So the timing is there, data collected, the electronic medical record access log, staff interviews, ICUs, SOPs on insulin administration, incident report. So the root causes identified: misinterpretation of the handwritten insulin dose due to poor quality, poor legibility, lack of double checking policy, uh, high risk medications, absence of standardized insulin administration training or a refresher course is needed, no barcode on or EMR system in use, contributing factors: fatigue, staffing shortage, environment, dim lighting during charting, communication, no verbal communication of dose, systemic, inadequate EMR integration or handwritten orders still used, corrective action plan, implement the insulin orders. Responsible is the IT or pharmacy. There is a timeline, there is a metric, that is the electronic medical record used for insulin. Mandate independent double check for all insulin administrations. ICU nurse manager would be responsible. Timeline 2 weeks. Audit compliance. Conduct insulin safety workshop. Quality of an endocrine team 1 month. Staff attendance rate. Upgrade charting stations with better lighting. Responsibility admin, timeline 1 month, lighting, lux measurements, monitoring, monthly audits of insulin administration, monitor hypoglycemic events, quarterly training refreshers, spot checks, lessons learned. Handwritten medication orders pose a high risk for errors. Insulin, a high alert drug, requires systemic safeguards beyond individual diligence. Sign off. And this is, then we can create, it is asking whether a fishbone diagram is needed. Yes, I'll say fishbone. So it is first giving me the points of fishbone diagram. Yes. It is taking some time anyway. Yes, it's almost ready now. So this is the fishbone diagram which is ready, and we can even download it, take a printout, put it on the wall. What could be the various factors? We can add our own also, but this gives the common reasons why a particular error occurred. So we will take another example. Paste. So there are residents who are unprepared, residents or interns who are unprepared for CPR drills. Investigate gaps in resuscitation training compliance. So let's see what it does. Event title: Unprepared residents in CPR drills. And problem: during a routine unannounced CPR drill, several junior residents were unable to perform basic life support correctly or locate emergency equipment. This indicated gaps in CPR training and retention. So it gives the timeline: unannounced CPR drill, team delay in chest compression and failure to use emergency equipment, stimulation paused due to safety concerns, debriefing revealed lack of recent hands-on training. Then data collected, training attendance logs, ACLS, BCLS certification records, simulation lab, usage data, resident schedules, faculty interviews, previous drill reports. And we can do the 5 whys, and as a result, there is no structured refresher schedule for CPR drills, over-reliance on online modules without hands-on practice, CPR certification not linked to clinical duties, simulation lab underutilized due to poor scheduling or coordination. Many of these points are very common to our medical colleges. Contributing factors: human residents busy, clinical load and burnout, educational, no feedback loop or remediation for failed drills, administrative training compliance not monitored in real time, and communication, inadequate handover from outgoing batches on emergency protocols. So make CPR recertification mandatory before ICU ward rotations. Responsibility metrics: academic office timeline 1 month, 100% compliance is needed. Implement quarterly hands-on CPR drills, simulation lab coordinators, ongoing attendance logs. Automate alerts for expired training via electronic medical records. In responsible medical education to MEU or IT department in timeline 2 months. There should be 0 expired records. Track drill. The quality control officer 1 month drill competency rate. And then monitoring and evaluation plan, drill completion logs, quarterly review of CPR, spot checks, dashboard tracking, compliance and expiry dates. So lessons learned, hands-on, recurring CPR practice is essential, passive training formats for inadequate emergency readiness, and certification must be integrated into real-time clinical responsibilities. And then fishbone diagram for this can also be created, or there can be we can ask it to create a technical training compliance dashboard. Proposal. Anyone who wants to ask something or say something at any stage is most welcome. So, objectives: track, identify non-compliant residents proactively, monitor drill, support remediations. Then pie chart, upcoming expiry alerts, drill performance keys, etc. All these can be created. The roles: the residency director, simulation team, residents, quality control officers, success metrics, etc. They can all be created. So we'll take another op. There is a trend of poor student performance and recurring low marks in pharmacology. It could be any subject, but we'll take pharmacology as an example, but this applies to all subjects. It could be even 1 year, not just 3 years. Even 1 year it can be done. Recurring low students marks in root cause analysis. So there is a team member, dummy, more than 35% of MBBS students consistently scored low passing marks threshold in midterms and finals with common complaints of unclear concepts and overloaded content. So the timeline: the July marks, September exam, January exam, April, May exam, student feedback indicates poor conceptual clarity. So data collected, exam score trends, student feedback forms, teaching logs, attendance records, faculty schedules and methods, review the attendance blueprint and MCQ validity, assessment blueprint and MCQ validity. And there is mismatch between taught content and assessed content. The root causes: overemphasis on factual drug lists versus clinical application, inconsistent teaching quality across batches, the faculty turnover is low, lack of active learning or spaced repetition, delayed student feedback response, no mid-year curriculum audit, human faculty burnout or under training in digital methods, assessment, no blueprinting or item analysis, student over reliance on last minute cramming, environment limited small group tutorials so many of these things may be new to us, but we all we can accept them, we can add to them, we can subtract to them, but they are really points on which we can take action rather than some kind of a gut feeling. I mean, they are pointers along which we can create new lines of action. So corrective actions, map curriculum to clinical cases, responsibility, MEU and HOD, timeline 2 months, and metric revised lesson plan. So we train faculty in active teaching. We can use some softwares in MEU, timeline 1 month, workshop attendance, the metric, use blueprinting and item analysis for all tests. The assessment leads the timeline is the next exam cycle, and of course the metric is the MCQ discriminating ahead. Monthly tutorials for at-risk students will be taken by the academic cells, start immediately. So there is a monitoring and lessons learned. Consistent poor performance is rarely due to students' efforts alone. Systemic misalignment between curriculum delivery, teaching methods, and assessment design must be identified and corrected proactively. At no stage we are blaming any individual. We are continuously working on this system. So in this we can create slides for faculty academic board. We can create the fishbone diagram, or we can create all also. It is writing in the Python language. But now at the end it will convert it into convert to PowerPoint slides. So it has created PowerPoint slides also for the faculty meeting. Us. Uh, okay, right now it says the file generation is not available, and But I can do one more thing. I can just copy these slides and go to Dr. Sitalal says, what are the key deficiencies in current patient reassurance strategies during pre-hospital care of venomous snake bites, and what measures can be implemented to enhance patient comfort and psychological supports in these challenging environments? Okay, we will just copy paste this, but oh, I'll put this here. Paste. But before that, I'll just copy these slides from here and then go to my Google Drive and I'll go to my Google Drive and then there I say create a new Google slide and okay. Then there is a Gemini is there now in uh, and I'll say in Gemini, okay. At present, this facility is not available in Google Slides, but it is available in Google Forms. But anyway, so we can end it here, and we will just apply Dr. Uh, Sitalal's uh, yes. So Dr. Sitalal has provided what are the key deficiencies in current patient reassurance strategies. So we just apply it and let's see what has it. This is in forensic medicine. Current patient key deficiency in reassurance, pre-hospital snakebite care, lack of structured psychological first aid, um, anxiety and panic, accessible tachycardia, increasing venom spread, inconsistent communication protocols, limited availability of supportive tools, overemphasis on physical stabilization alone, and no continuity of emotional support. Immobilization and transport are prioritized, but simultaneous strategy exists for managing fear, pain, anticipation, or family anxiety. Recommended measures to enhance comfort, train responders, uh, system-wide ambulance implementation level and examples, simple scripts, you are stable, help is steady, ready, we know what to do. Use structured reassurance phrases, field protocol, you are not alone, anti-venom works and is on standby. Introduce pictorial or voice-based calming tools, resource tech, culturally adapted response protocols, document emotional state at field level, EMR and field log is responsible. Tag the anxious but responsive, calm, understands plan. So these are root cause themes, the fishbone summary. Human factors, limited training in empathy under stress, methods, no standard script of communication SOP, environment, loud, chaotic, scene interferes with reassurance, measurement, no metric for psychological comfort recorded, technology, no tools, for example, mobile-based apps or visuals. And if we want to create a visual fishbone diagram, or pre-hospital PFA script guide or design training module, everything can be done. So it is generating. So the fishbone image is ready. We can download it and paste it on the wall of the forensic department and act on it. The efficiencies in patient reassurance during pre-hospital care of snake bites. Human factors, methods, environment, technology, training, measurement. So the tool is available to all of you, and I'll just send the link on the chat. Were you able to see it, or I didn't share the screen?
We can see it, sir.
Okay, thank you. Yes, I have taken 2-3 days to make it. but at present it is a free version. So far about 150 people have used it, but only 5 have filled the feedback form. But I don't know how they are using it. So if you all use it, it's a beta version. We can add more things, and it can be improved further. Yes, and if it serves the system, there's no harm in, I mean, it can be kept free, no problem. The objective of MEUINDIA is to improve the Indian health system, which should be better than the global levels. We see by 2047 India as the hospital for the whole planet. So for this, whatever infrastructure we have, it is very good infrastructure. But only thing is we have to clean it at different levels. From the level of a ward, a classroom, to the head of department level or departmental level, institutional level, health university level, and also the national level. But and these tools they are available at all levels. Only we have to apply them. They were available earlier also to knowledgeable people, but because of certain problems, it was not getting applied. Now it is easier to apply it. It is nothing new, but only the different technique. I remember I attended a 2-day workshop only on root cause analysis at Maulana Azad Medical College. It was organized by Dr. At that time, Dr. Satendra, who is, and we spent 2 days only on root cause analysis. Community Medicine Department of Maulana Azad Medical College organized it, but we could never apply it. So, any questions, anyone? Or comments?
ये अच्छी चीज है सर, बढ़िया है। गुड है, मतलब वही थोड़ा और इसके साथ टाइम स्पेंड करने की जरूरत है, बट हमारी कोई
वो
भी।
तो है,
हाँ जी, हाँ जी।
बस अपनी डे टू डे इश्यूज पे के टाइम इनको यूज करी जाओ एंड यू विल सी
हाँ जी।
a big change.
यस सर।
So I'm also uh, sharing a feedback form. Rather, two feedback forms. One for today and one you can So please fill this feedback form.
Okay, sir. Thank you.
Okay, those who have submitted, they can leave.
Thank you.
Someone is saying that is it student friendly also? I mean, students can also point out any of their own problems. In fact, I had created one for students' mental problems, but ChatGPT didn't allow me to share it. I can use it only for myself because it can look into the problems of suicide, etc. For sometimes it hallucinates also. So I think we can end it now. There are no more coming. Those who have not filled the feedback form are requested to fill the feedback form. It helps me take some actions. Thank you very much.